Hello, world. Uh, Good morning, good afternoon, good evening, for our friends and colleagues from around the world. We are today with Dr. Ahmed Ayoub. I'm very happy to be here with my great friend Ahmed Ayoub from Egypt. He's the president of Egyptian Society of Oral Implantology. And thank you so much for your presence today with us. And I know that we will have a very good lecture from my friend Ahmed Ayoub. Thank you so much. The floor is yours, my friend.
Hello, good evening, good morning, good afternoon, wherever in the world you are. I'm really very happy to be here with you in this lecture, and it's nice to see my dear friend, Dr. Carlos, again in online, because we used to see each other in a lot of congresses, but of course you know now about Corona time, and we are all locked down in our house. We are not working, we are not doing anything. But I believe it's fantastic because now we have the opportunity for a good exposure. Now we are sitting in your home on the couch and you are seeing a lot of speakers that you used to pay a lot of money to see them. And and of course for all speakers they have a good opportunity to expose their work to all audience. So I believe Corona, it's not that bad. Of course we lost a lot of time, we lost a lot of money, and we still don't know what will happen next. I'm not going to say what will happen next month, but what will happen tomorrow, because you never know what will happen really tomorrow. So hopefully we will get rid of this virus very soon. I hope so, because it's terrible now. It has been several months and we are locked down. We are very afraid to work in our clinics. We can't work for our patients. It's terrible now. So let me introduce myself to you. I'm the president of the Egyptian Society of Oral Implantology. My name is Ahmed Ayoub, and I'm visiting lecturer in Bari University in Italy. I'm a board member in London Oral Restorative Academy, and I have a dental implant practice. My practice is limited only for dental implants since 2007. I started my first dental implant in 1998. It was my first dental implant, and we established our Egyptian Society of Oral Implantology in 2009. This is a part of my teamwork. This is my senior teamwork, and I give them the credit for all the work I'm doing, because they are helping me in everything. I have all specialties around me. They are doing everything. I'm doing very just when I'm doing surgery, I just tell them, okay, please open the flap like this. They open the flap. Okay, I place my implant or whatever, bone graft or whatever the procedure. Okay, guys, who's going to close the flap? And I just leave. They are doing everything for me. They are taking the pictures. They are doing perfect work. So I'm giving them all the credits of my work. Actually, the Egyptian Society of Oral Implantology, it's a non-profitable organization, and the aim of this organization is to spread the dental implant education all over Egypt, all over the Middle East, and all over the world. We have our educational center in Egypt. We have a clinical attachments. We have clinical courses all over Egypt. We have also courses in outside Egypt, in Europe, in Middle East. You see these pictures in Saudi Arabia. We have pictures in Bahrain, in Dubai, everywhere, in Libya, in Morocco, in Algeria. So all over the world, at least Middle East and the part of Europe, is covered by the Egyptian Society of Oral Implantology for the purpose of dental implant education. This is what we really like. You will find us everywhere, and even online, as a great opportunity I got to be here with you to introduce not my work, it's our work, it's my teamwork, my teamwork, because we are working as a teamwork, and as I told you, they are helping me a lot. Let me go to the lecture, directly to the lecture, and I will tell you something I know of course, you know it very well, that osseointegration is no longer the only parameter for success of implant therapy. Even if you do a very good ceramic restoration, same contour, same shape, same translucency of natural dentition, maybe the patient won't be satisfied, because still the patient now think about the gingiva, he knows about papilla, he knows about keratinize, because I will be surprised, but your patient knows very well about this. So of course, you know about something what we can call emergence profile. Emergence profile is something very important. Emergence profile is a profile or the contour of the tooth and restoration while emerging from the gingiva. To achieve a good emergence profile, you need to have two things: soft tissue and a good restoration. Of course, when we are talking about a good restoration, you have to deal with a good lab. But when we are talking about soft tissue, you need to reshape your soft tissue in a good way so you can create a good emergence profile and a good soft tissue shape around your restoration. And when we talk about soft tissue manipulation, of course, we talk about healing abutment. Everyone is using healing abutment to reshape his soft tissue and to get a good emergence profile. And we can say this is what we can call a good emergence profile. This is a good emergence profile you can achieve or you can get, because we could manipulate our soft tissue in a nice way. But there is something very important you have to know. As you have a biological wedge around the tooth, which is epithelium and connective tissue, also you have a biological constant around the dental implant, which is a 2 millimeter of epithelium and 1 millimeter of connective tissue. So you have a biological wedge, you have biological constant of around the dental implant, and remember, it's 2 millimeter of epithelium and 1 millimeter of connective tissue. So all over, biological wedge or biological constant around dental implant is 3 millimeter. Albert Einstein said once, if the facts don't fit the theory, you can change the facts, you can change everything. You will have to change the facts when you have a patient with high static risk factor. And here, what is high static risk factor? I'm talking about smoker patient, high static expectation, high lip line, which means a gummy smile, and patients sometimes with horizontal bone defect, patient with thin gingival bitype. How are you going to deal with this kind of patient? Especially this patient with thin gingival bitype. What is the problem with thin gingival bitype? The problem is here. Thinning or destruction of biological constant thickness, which is 3 millimeter around the dental implants, will lead automatically to peri-implant bone loss. So when you place an implant in 1 millimeter in a bone which is surrounded by 1 millimeter thickness of soft tissue, what will happen? Bone will undergo resorption to accommodate for the biological constant. So you will lose 2 millimeter of bone. Oh my God, this is terrible. If you place your implant in 2 millimeter thickness soft tissue, you lose 1 millimeter of bone to accommodate for soft tissue or for the biological constant. So it's a big problem. So a balance between anatomical and restorative concentration and soft tissue management is really important to stimulate natural appearance. You have to simulate the natural appearance of the tooth. So when you have a soft tissue defect like this, you will have to deal it with a way or another, because soft tissue is creating the harmonious aesthetic frame of the restoration. So you will have to deal with a way or another. And the importance of soft tissue thickness around dental implants for maintaining of functions, aesthetics, have been widely reported in multiple publications. You can find a lot of publications. The one I shed here, the one I'm showing here, sheds a light on the importance of thickness of soft tissue and implant angulation around the dental implant to maintain the bone. So here we have a thin peri-implant tissues, less than 2.5 millimeter, is associated with increased crestal bone loss. And I already explained to you why this happens and how this happens. Increase the incidence of marginal tissue recession with buccally angulated implants. So it's not only managing soft tissue, it's placing also the implant in the right position, because if you place it in a buccal inclination, you will have marginal tissues recession. So it's very important to manage the peri-implant soft tissue and to increase thickness of peri-implant soft tissue. And of course, when someone is talking to you about soft tissue management around dental implant, you will think about what? You will think about connective tissue graft, free gingival graft, rolled flap, blah, 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 blah. Of course, it gives you a fantastic results. If you put a connective tissue graft, free gingival grafts, or whatever, you will get a fantastic results. But there is always but. You see, it gives you a very good results if you take a connective tissue graft. And of course, everything I'm saying, you will find down here my reference. It will give you a very good pink aesthetic score, but it's not easy. It's a technically sensitive procedure, because I'm asking you now, how many of you can do a very good connective tissue graft? Not a lot of you. Few people can do it. And imagine that you are the patient and I'm telling you, okay, come on, I will take some tissues from here, put it here. I will get a block of bone from here, put it here. Oh my God, doctor, what you are going to do to me? So take care of your patient. He's a human being. So don't think every time to take tissues from here, to put it here, to take bones from. No, you have to be less traumatic as much as you can. As less as you go traumatic, as much as you will have a fantastic results. When you deal with your tissues with a nice way and a less traumatic way, your tissues will surprise you by the outcomes that you will get from it. You can even use a cellular dermal matrix, but this patient, your patient or the patient, when he goes to a dentist, he will tell him, you have a thin gingival biotype. I will take connective tissue graft from here, put it here. The patient will run to another dentist. Come, I will take a free gingival graft to put it here from. The patient will escape and comes to you. You will convince him. You know why you will convince him? Because as Tom Abbott said, it's not about being better. It's not about being the best dentist in the world. It's about being different. You need to give your patient a reason to choose your business. So when your patient comes to you, he will tell you, doctor, I have a problem with thin gingiva. You will tell him, don't worry, I will manage. But he will tell you, doctor, I don't want you to take tissues from here to there. You will answer him, no, I'm not going to do this. I will do it with the least traumatic procedure. How can I do this with the least traumatic procedure, with a simpler way, using fibrin? Fibrin is the answer, and fibrin is a present. Fibrin is the future even. Because we know that when I'm talking about fibrin, I'm talking about platelet concentrates actually. But platelet concentrates, because everyone used to talk about PRF or CGF or PRGF or whatever they are. They used to talk about platelets only, platelets secreted from gross factor secreted from platelets. But don't forget that fibrin is extremely important. So when I'm talking about fibrin, I'm talking about all products, CGF, PRF, PRGF, PRP, because I believe that it's almost the same. It's only commercial difference or very few difference between this one and this one. I used to use the PRF, and nowadays from maybe 3 years I shifted to CGF just because I have the machine of CGF. And you can use CGF or PRF to achieve soft tissue augmentation, especially in a static zone. You can use CGF, you can use APRF, you can use IPRF, you can use whatever you like in this procedure. How to obtain CGF? Just you collect blood from your patient like this in specific tubes. Then you put your tube. In my condition, I'm using the Medifuge from Silfradent in Italy to get the CGF. At the end, you can see here I'm having the CGF here, and down I have red blood cells. I don't need red blood cells. So you can see here it's the end product, the CGF, but I have to cut the red blood cells because I don't need red blood cells. You see here I'm cutting the red blood cells, and this is the end product. But of course, inside you have a lot of acellular plasma that you don't need. You need just a fibrin with a few with platelets and white blood cells and stem cells inside. So just we compress this piece of CGF, and this is the final product or end product. We can use now this end product or final product in our this is what I was talking about, is a CGF. We can use this in increasing the thickness of peri-implant soft tissue to our patient, as I'm going to describe to you next. I have a lot of publications. I have about 24 publications about CGF, about PRF, about sticky bone, about the one who invented Carlos is a CGF with Albumin CGF. I have publications. If you go to ResearchGate and you write down my name, you'll find I have 24 publications, and I have a lot of reads. It was 15,000 from a couple of months ago. It's now about 19,000, and I have 46 citations, which is a good number. So you can go to ResearchGate and you will find all my publications there. And now, how to manage gingiva around, or soft tissue around your dental implant in a nice way, in a gentle way. I will introduce to you about 4 techniques, and let's start by my first technique. I developed this technique, and it's called reverse mid-crestal incision. A reverse mid-crestal incision is a technique developed by me in 2013, and I published in 2016. It was and this technique I developed to create an interdental papilla between mesially and distal to your restoration in the aesthetic zone. So let me show you first this video animation and how this technique is working in a very easy and nice way. All you have to do is a Bucco palatal incision, just a Bucco palatal incision, and push your tissues mesially and distally. Take out your cover screw. You can do this only in thin gingival bitype. You don't need it in thick gingival bitype. In thin gingival bitype, take out your cover screw, put a narrow healing abutment. Leave your narrow healing abutment in position for about 1 week. After 1 week, take it out and put a wider healing abutment, and then take out the wider healing abutment and put your final restoration. What is happening here? This is the technique. Let me explain to you what is happening here. I will explain on a clinical case. Here you have an implant in a good position, thin gingival bitype, which is pinkish white in appearance. And all you have to do is a Bucco palatal, just one Bucco palatal incision, as you can see. And then you push your tissues mesially and distally, take out your cover screw and put the narrow healing abutment. And why I told you have to do it only in a thin gingival bitype, because in a thick gingival bitype, you don't need, you have a lot of gingiva. You can push it. You can just take your gingiva out by diode laser or a tissue punch and push the remaining tissues mesially and distally. If you use this technique in a thin gingival bitype, you will have some problems of taking out the cover screw, because the cover screw will be covered with thick gingiva, thick tissues. So just push mesially and distally and put your narrow healing abutment. Wait for 1 week. What will happen for 1 week? Let me show you a fantastic picture, one of the best pictures in this presentation. And you can see here the tissue expansion. I can call it a tissue expansion instead of calling reverse mid-crestal incision, because I was about to call it reverse mid-crestal incision, but my colleague who published this with me, Dr. Sulafa Bilal, she told me, no, it's better we call it reverse mid-crestal incision. But what we are doing here, we are doing a tissue expansion. And as you have done your incision Bucco palatal, so you're expanding your tissues mesodistally. And the most important thing, that you are preserving your blood supply from the buccal and palatal tissues. Because you can use, someone will tell me, doctor, we can use a palatal strip flap. We can use Palachi technique. Yes, with palatal strip flap or a Palachi technique, number one, it's very difficult and it requires a lot of, it requires tricky manipulation, as well as in whatever other techniques, you will cut the blood supply either from buccal or from palatal. But in this technique, you're preserving and you keep on having your blood supply from buccal and palatal mucosa, especially palatal mucosa, which is highly vascularized, and also buccal, and you have no scar tissues. And then putting a wider healing abutment, you will have a better soft tissues around your implant or around your restoration. Look, in another case, here is another incision buccopalatal. Look at the tissue expansion, look at the blanching in your soft tissue, mesially and distally tissue expansion. Then you started to have an emergence profile. This is not a perfect emergence profile. You need more expansion for your tissues. So I put a wider healing abutment, and with more expansion here and there, you get a better emergence profile, and you can get a better statics or better papilla for your tissues. So now, number one, reverse mid-crestal incision to get a buccopalatal. You see, you have make a buccopalatal incision and narrow healing abutments and wider healing abutment to get papilla or to create papilla. Second technique we are going to talk about is the pouch technique. The pouch technique is also a technique I developed in 2012 and I published in 2016 with Dr. Sulefa also Bilal, and this technique was meant to increase the thickness of peri-implant soft tissue around your implant. So let me introduce to you, when you have a case like this, you have a thin gingival bitype and you have a defect, you need to manage this. We published this in 2016 and we called it soft tissue augmentation with PRF using a minimally invasive pouch technique. So this is what I called my technique, a pouch technique, minimally invasive pouch technique. Let me explain to you by video also again. Let me show to you. Here is the video working. All you have to do is just a small incision mesodistally on the buccal aspect of your tissues if you have already your implant. So you have a defect and you need to increase your soft tissue, either the time of implant placing or even later on. But I prefer now to do it with the time of implant placement to prevent further bone loss or further bone resorption. So you insert you create your pouch, you make your incision, you insert your periosteal elevator to create the pouch, and then you fill the pouch with PRF or CGF or whatever the product you are using. It doesn't make a big difference. Then you take sutures, of course. And now, what is happening? What will happen after you put your CGF or PRF? Because some people are saying, yes, doctor, but this CGF or PRF is going to resorb after a couple of months, a couple of weeks or 3 weeks. No. Let me tell you something, and I will show you by pictures now. PRF or CGF is not going to resorb. It's going to be a part of the new tissues. First couple of weeks, PRF or CGF will act as a filler, just a filler inside the pouch. Then what is happening normally in this area? Imagine if you created your pouch and you didn't put some PRF, what will happen inside? Some blood clot. And some blood clot, and then some soft tissue will appear, but you will have some collapse. But now with PRF or with CGF, you have a filler that will maintain the gap, will maintain the horizontal dimension, and the new tissues will start growing inside the PRF. Here the fibrin will act as a mesh for your new tissues. So now what I'm creating a new connective tissue inside you. Instead of getting connective tissue from somewhere and putting it inside, no, I'm creating connective tissue inside you. So the PRF will act as a spacer or a filler, and then new tissues will grow and will migrate inside this filler. So you will have a horizontal dimension, and you will have all over, you will have soft tissue around your implant. Here I place my implant palatally. As you all know, you have to place your implant palatal. You put some bone graft buccally. The patient is not happy because she has this defect. She told me, doctor, I don't like this, so what can I do? Simply my implant in a good position. So I do just the mesodistal incision, creating my pouch, inserting my CGF inside the pouch, and look at this. Look at this. And I'm going to use a magnifying lens here to show you something very important. Look at this. The white is a fibrin network, because let me go back to this picture. I put a piece of PRF between the healing abutment and the implant and the other side inside the pouch. Okay, next. After 3 weeks, let me show you here. The white is the fibrin, the red is the new tissues. And day by day, these white colors will become red. What is happening? The new tissues are migrating inside the PRF. The PRF is replaced by new tissues. The PRF is a niche for the new tissues. It's how can we call it? It's a scaffold for the new tissues. And then later on, you see, now I have a huge band of keratinize because I have a very good keratinize because around my implant, you see, I have a very good, this was a PRF outside. And of course, inside I have my connective tissue. And here is the pre. You see the defect, but we have no more defect. You may need to redo it another time in the rare case with very thin gingival biotype, but usually we do it once. And 1 year later, when the patient came to me, I took out the crown for cleaning purpose. And you see still, I have a very good soft tissue stabilization around my dental implant. Let me show you another case. And this is a video. By the way, I have a channel on YouTube. You will find some lectures on this channel, and you will find a lot of videos, maybe more than 90 videos explaining a lot of techniques, and you can follow. It's not Ahmed Halim because my full name is Ahmed Halim Ayoub. Ayoub is my family name, and some people, because the problem came that some people calling me Ahmed Halim is my father's name, Halim is my father's name, and some people calling me Ahmed Ayoub. So anyway, the channel is called Ahmed Ayoub, Ayoub. You can follow. You can see a lot of videos about everything. Nowadays, I'm working in immediate loading and compressive implants, so you'll see some videos on immediate loading and compressive implants. Now, let me show you a video how to do this pouch. First of all, you do your mesodistal incision. You can see it's a mesodistal incision. I have a nice music, but unfortunately you can't hear it. And using a periosteal elevator, you are creating your pouch. Here I was using a big periosteal elevator. Actually, I had to use a smaller one, but anyway, you see the pouch. Here is my pouch, you can see. Maybe you can extend your incision a little bit, but don't include the papilla of the neighboring teeth. Don't include the papilla. And you know you are inserting now, we are inserting the CGF or PRF. Another piece of CGF. You see now I have a filler inside the pouch. You see here after a few weeks of healing, it's very nice. And I will show you later on. This is a pictures of the cases of this case, pictures of this case. And you see I'm putting the CGF in between healing abutment and the other side inside the pouch to increase the keratinized mucosa around the dental implant, my last layer of CGF. And you see here, I started to have a good keratinized mucosa and thickness of soft tissue around my dental implant. And let me show you 3 years later. I'll show you a nice picture. This picture was just 3 months later, and I wasn't happy of the results. I don't like the appearance here of the emergence profile, but the patient, she was very happy. She's not a gummy smile. She told me, doctor, I'm happy. It's okay for me. Please don't do any further procedures. I told her, okay, if you are satisfied. I'm not satisfied, but it's okay. And she came to me 3 years later. She's a friend of my assistant. I told her, come, I would like to see your teeth. When I opened my mouth, I was surprised from the fantastic outcome of my tissues. What happened? Because you are very gentle with your tissues. You are treating the patient's tissues with a very gentle and very nice way. So the outcome is fantastic for you. The less traumatic you're dealing your patient or your tissues, the better outcome you will get. And you can see. Everyone can do this because it's very simple. This is my school in dentistry. It's the art of simplicity. How to do everything in a simple way, or as they say, it's a kiss. Keep it simple and silly. How to do everything in a simple way. And now I will show you another modification for the pouch technique. I didn't publish because it's just a modification for the pouch, and it's called the Vista technique. The only modification is, instead of making a Bucco palatal incision, it's better when you have your implant placed long time ago is to make a vertical incision and making your tunnel or your pouch here from mesial or distal to the implant. You see, you're creating your pouch because already you have your implant. Even if you have a restoration long time ago, but the patient is not happy with this horizontal soft tissue defect, so you can create your incision from here, put your CGF inside, put it inside, and then you will have better results later on. On a patient I'm showing to you, it's a minimal exposure, it's a minimal incision, and it doesn't require a tricky manipulation, doesn't require a specific microsurgical tools. No, you can do it with any scalpel you have, with any periosteal you have. You can do it very easy. You're less traumatic, it's less traumatic to your patient. You're creating here your pouch, putting your CGF inside, and you see I have a better horizontal tissues, much more better. I'm showing you here the pre-operative, and here is the final. Finally, of course, it's much more better results, pre and post-operative. And as I told you, when you wait more and more time, you will get a better results. You can see here is a 1 year follow-up. You see here is a soft tissue. It's a very good keratinized because around your soft tissue. Let me show you another case. This patient placed her implant with another surgeon. She came to me, she told me, doctor, I have this canine and I don't like the appearance. They told me that you can do it in a gentle way, because my surgeon told me he will take connective tissue graft. My surgeon told me he will take a part from my palate and put it here. I told her, no. She told me, yes, I heard that you are doing it in a nice way. I told her, okay, no problem, don't worry. So it's the same. You can make your opening. You see, just one incision, very small incision, and create your pouch with a periosteal elevator. And you see here, I started to create my pouch immediately. I started to have better results. What is happening here when I put my PRF or CGF inside? The PRF or CGF, by its weight, it's pushing, or we can say it's pulling the tissues down. It's pulling the gingiva down. So you have better results. Just 1 or 2 sutures, very nice. And finally, just few weeks later, she was okay. And I'm sure she didn't come back to me, but I'm sure if this patient comes back to me, because it has been now 5 years, I'm sure if she comes back now, I will have better results. But of course, when the patient is satisfied, he never comes back to you. When the patient is having a problem, he's coming back to you to make troubles, to try to take his money, and so on. So no news is a good news. And my last topic will be the custom-made healing abutment, which is really, I really see that it's really interesting, because to create a good emergence profile, you need to use healing abutment. And when you are using a healing abutment, you know, in any company is having healing abutments. How many shapes of healing abutments in each company? 5, 6, 10, 20, 50? Of course not 50. They have maximum 20 shapes. Okay, very good. So what is the role of healing abutment? Is to reshape patient's soft tissue to create a good emergence profile. But my soft tissue doesn't look like your soft tissue, doesn't look like his soft tissue, doesn't look like his soft tissue. So I can't use only 10 or 20 healing abutment to reshape soft tissues of thousands of people, because I need to reshape it according to his original looking soft tissues. So we used to use, instead of using healing abutment, we used to use a temporary crown to reshape our soft tissue around the dental implant. So let me show you by clinical case, just one Bucco palatal incision, putting using a plastic temporary abutment to create a temporary crown. Instead of putting a wider healing abutment, you remember I make a one Bucco palatal incision, then a narrow healing abutment, then a wider healing abutment. But instead of wider healing abutment, I'm using a temporary crown. I just used a ready-made temporary crown. Here is a ready-made temporary crown, and see, in my teamwork, they started to put some flowable composite to reshape the cervical part, or to reshape the cervical portion. But you can see here, yes, we have a very nice area in the cervical area. Composite is very nice. But usually we put a flowable composite according to what we can, according to what we think, because I think, yes, I need to put more flowable composite here, I need to put less flowable composite here, but this is not scientific, because I always need a guideline to put here flowable composite more than here it needs less flowable composite, and so on. So I need a guide. Where is my guide? Let me show you first this case. So the implant, the temporary crown was placed immediately. Soft tissues are becoming better and better, and when we take out the temporary crown and we put our final restoration, we have much more better soft tissues. But I was looking for a scientific way to put my flowable composite till I found this software. It's a plug-in on software called Blender. Blender is a three-dimensional 3D software, and I found this plug-in created by a brilliant dentist in the States, Baron Grotter, and he created this. All you have to do is to you put some information about the shape of the teeth, about the number of the teeth, about is it small, is it medium, is it large, blah blah blah. Some information you just enter, and at the end you have this block. Then you 3D print this block. You see, you can choose a lot of emergence, deep bowel, hourglass, a lot of emergence profile. Then you 3D print your block. Then you put your temporary abutment, or even you can use a tie base and put flowable composite around it. Let me show you a video to explain to you how can we use it. I can call it a custom-made healing abutment. So you see here, I'm putting separating medium, etching and bond to my temporary abutment, or even you can use a tie base or use a final abutment, doesn't matter. Flowable composite around, then curing. Maybe if you need to make a whole temporary crown, you can do it. You can add more and more composite, and you can make a whole temporary crown for your patient. And now what you have a custom-made healing abutment for your patient. You see, you have here a custom-made healing abutment, which is customized for a specific tooth. Not a healing abutment for anterior segment, no. This is a custom-made for upper central incisor, upper left central incisor, custom made for upper right central incisor, for upper left premolar, with a patient, for a patient with a big teeth, with a medium-sized teeth, with a small-sized teeth, so you can customize everything. Of course, you are getting much more better results for your patient. I'll show you in this case. This is one of my beautiful, I love this case because it's a beautiful case. Patient with missing upper centrals, one is broken and one is totally extracted. He had an accident, and you see we don't have, in one of them, we don't have a buccal plate of bone. So here is the clinical pictures. You see we have a big mass here, but let me go back to explain or to show you something. Here I don't have a buccal plate of bone, but I have a treasure of palatal bone I can use. And of course, you all know that in immediate placement, you have to place your implant palatally. So, okay, I can use this to create a new, you see here, I have a big mess and a big problem. Either you can go for socket grafting in a case like this. You can go for socket grafting. You can just put a bone graft and wait for a few months and place your implant. Or you can create a new socket palatal. You see, I'm creating a new socket palatal. Here is my paralink pins, and I'm leaving my here my sockets intact. It's a new, totally new sockets palatal. You see, I have my new sockets here. Then putting the implants. I have here one implant, second implant. Of course, the implants are, I have exposed threads. What I have to do here is to put, of course, to put bone graft. And it's a fantastic place to put bone graft because you have a 5 volts defect here. So it's very good to put bone graft inside. I'm using sticky bone, and actually the bone graft inside I'm using is allograft coated with human albumin. I used to buy it from a company in Netherlands called Orsocera, but nowadays I'm preparing the albumin in my clinic, so I'm using allograft, and I put patient albumin and in the form of sticky bone. And of course, the role of albumin is the culture of stem cells. When you have a lot of albumin, you have a lot of stem cells, so better and faster healing. So you can see the whole implant covered by bone graft, and covering the whole area with bone graft, sutures, and then a nice looking gingiva. But what about the implants inside? Let me first show you. It's a bucco-palatal incision. Now to create papilla, I'm making a bucco-palatal incision, putting a narrow healing abutment, and look at the blanching. What I'm doing here, extending the tissues. So let me call it tissue extension technique, tissue expansion technique. I'm expanding the tissues. Now I'm taking it out and putting custom-made healing abutment, and I put temporary crown, but I didn't take a picture, forgot to take a picture for this. And now you have a good emergence. This is what I can call a good emergence profile for my patient, taking an impression, and look at the pictures pre and post. Look at here. I placed my implant palatal. Look at the implant. Look at the buccal plate. Look at the buccal bones that I got. It's better than the original patient bone. Look at the. Let me use the magnifying lens to show you the difference in trabeculation. Look at here. It's the original patient bone, but look at the buccal plate of bone. Look at the difference. I have much more better quality than the original patient because of type of bone graft, of course, I was using. And finally, I got a good results for my patient. My patient was satisfied because I used the right bone graft, I used the right implant, the right technique, and the easiest soft tissue way to manipulate my patient's soft tissue. I will show you another picture. One of my teamwork has done this this case in my clinic also. The patient wasn't happy with the appearance of this terrible bridge. He took out the bridge and he placed the implant for the patient, and later on the patient came for soft tissue management and impression and so on. So we made our bucco-palatal incision, you can see here, and we created our custom-made healing abutment. This is very important to do, our custom-made healing abutment. And look at the tissues now. Look at the tissues. I have a good tissues now. I started to have a good emergence profile for my patient. And let me show you the final results for the patient. Look at the thickness of soft tissue. Maybe the lab maybe has done a mistake here he had to leave a space for the soft tissues here. He didn't do it. But if he left space here, it would be fantastic. But at the end, the patient was very happy and was very satisfied, and she had a nice smile at the end. She told me, I'm satisfied. I told her, you have to do veneers here because you see the difference. She told me, doctor, I'm very satisfied. This is much more than I expected. And another case from a colleague of mine, he also in my clinic, one of my teamwork, he placed the implant, and at the time of soft tissue, we created our Bucco palatal incision, as you can see, put a narrow healing abutment, then a custom-made healing abutment. This is a custom-made healing abutment, and you can see here I have now a good emergence profile for my soft tissue around the dental implant. So he fabricated his final restoration. This is a day of final restoration, and let me show you 3 months later what happened. Look at the soft tissue. Let me go back. Look at here, it's not good, huh? But wait, look at your soft tissue. Why I got this result? Because I was dealing with my tissues in a nice way. It's like when you would like to date a girl. Either you go to her, girl, come with me to drink some coffee. She'll tell you, no, I'm not coming. Or you can go with some flowers to her. You are very beautiful today. You are more beautiful than those flowers, and you give her the flowers and tell her, can you please come to have a drink with me? She may come with you. This is what you have to do with your soft tissue. You have to be very gentle and very nice with your soft tissue. Finally, let's go to our conclusion, and let's say implant therapy in aesthetic zone requires really careful planning and sequencing of the treatment. You have to do some steps. Hard and soft tissue deficiencies may require multiple procedures and have varying degrees of predictability depending on the size and nature of the defect. Preservation of the natural soft tissue architecture may optimize results and decrease surgery-related morbidity. And my conclusion is the use of growth factors concentrates in the form of PRF, IPRF, TPRF, APRF, CGF, PRGF, PRP. It will lead to better aesthetic results on soft tissue level with the advantage of less invasive technique. And let me put hundreds of lines under less invasive techniques, because less invasive techniques, this is very good, less invasive technique. And better wound healing, of course, which enhance the clinical end results and increase patient satisfaction. At the end, let me ask you, do you know who is this wonderful, fantastic girl? Who is this girl? She's Cinderella. You know the story of Cinderella, and you know the moral of the story. Cinderella, she never asked for a prince. She was just asking for a night off and a nice dress to go for a party. She wanted to go to a party, but she has done everything in a perfect way. She has done everything in a nice way. And at the end, the prize was a prince. So what I'm telling you, you have to do everything in a simple and nice way. Keep it simple and silly. KISS technique. Keep it simple and silly. If you do it in a nice way, in a simple, in a silly, in a gentle way, you will be surprised from the outcomes that you will get from your tissues. Really, you will be surprised. Don't tell your patient, I will take soft tissue from here to put it here. I will take a piece of your tissues from here to put it here. Look at the picture. You're already very scary to your patient. You're very scary to your patient. So you have to be gentle for your patient, please. You don't have to put tissues from here to there, to take bone blocks from here. There is always a shorter way. There is always a shortcut to manage this way. So please try to be less traumatic to your patient, and you will be surprised from the patients coming to you, because the patients are always telling each other. You know, patients are very well educated now. I have my channel on YouTube, and you know, this channel is for dentists, but some patients coming to my clinic because they see videos on my channel. They are looking for dental implants, and they see when you are doing a channel and you have a lot of followers on YouTube, he's a good dentist, and they know about papilla, they know about sinus, they know about everything. So please, be nice to your patient, be nice to your patient's soft tissue, be nice to your patient's hard tissue. And thank you very much for attending this lecture with me. It was really a pleasure for me to be here with you. I hope you enjoyed, and I hope it was beneficial to you. Thank you very much.
Thank you so much, my friend. That was a beautiful presentation. Thank you so much.
Thank you,
I have one question, not one question, maybe one suggestion, but maybe you already did it because about the punch technique. Probably you already used the ALB CGF or ALB PRF to substitute the PRF for this technique, right?
Mm-hmm.
What's your idea about the ALB PRF or ALB CGF to substitute the PRF, the standard PRF in the punch technique?
You know, I will tell you something. I believe there is no difference between all of them. I mean, CGF is like PRF is like. I believe there is no difference. If you are using this one or this one or this one, you will almost have the same. Actually, recently I started to use Albumin CGF.
Yeah, that's what I'm saying. I'm saying the albumin
it's much
plus
more better.
PRF or albumin plus PRF. Anyways,
Yeah.
the question
It's
is
because
not
you have a wider, you have a
PRF.
big mass.
Yeah, because we have a huge mass and huge mass at that moment, and then we have more time for reabsorption.
Yes, exactly.
That's what I mean. And then probably you already did it. Yeah.
Yeah, I did it, but it needs a bigger pouch. Because in small pouch you have to use the CGF, but in big pouch you can use the albumin CGF. Now I'm using albumin CGF everywhere, not even normal CGF anymore.
Yeah, albumin. I agree. I love it. The technique, your technique was very nice, and you are very gentle to handle the soft tissue, and then that's the important thing. I think that's the important for not only for periodontics or implantology. I think that's important for all of dental surgeons around the world. And another thing is the question about the STL file to produce that device in a 3D print. I think that's possible to share this STL file.
I can send to you, of course I can send to you.
Perfect. And then we can share this technique for sure. That will be awesome, because that almost we already have some device like that with Dr. Mizelli from Venezuela, and he called umbrella technique, and that's an amazing technique, and I think that's very good for our patients. This question about the emergence profile.
Of course.
Thank you so much, my friend. Thank you so much for your attention. Thanks so much for your lecture. Thank you all around the world. Thank you, colleagues. Thank you, friends, in this webinar today. And I hope to see you soon after this time of coronavirus.
Thank you, Carlos.
Do you have something to say for our audience?
I think there is. I have some questions because I can see the presentation from my mobile phone, so I can answer quickly the questions. How can first question is how can PRF become a membrane? PRF is already in the form of membrane, so you don't have to do it. Can we use PRF with collagen membrane together? Yes, if you would like to, you can do it, but no need to do collagen membrane. But if you are interested to do it, okay. Doctor, another question: what is the difference between PRF and CGF in terms of their uses? As I told you, I believe it's all the same. You can use whatever the device you have. If you have the device that produces PRF, use PRF. If you have the device that produces CGF, use CGF.
It's only branding.
No?
It's only a
Yeah,
brand.
it's not exactly. How to make albumin in a clinic? Can you give some insights? It's a big story.
I will teach it tomorrow. Don't worry.
Very good. Okay, Dr. Carlos will talk about it. Very good.
Tomorrow.
Perfect. So I think there is no more questions. And again, thank you very much, and thank you for attending the lecture. Thank you, Global Summit, and thank you, my dear friend Carlos.
Thank you, my friend. Have a great evening.
Thank you. Same to you.
Thank you all. Bye-bye.
Bye-bye.